Chapter 30, Promoting Bowel Elimination. These are the theory objectives for this section of the chapter. These are the clinical objectives for this section of the chapter. Okay, so structures involved in waste elimination. So you have the bowel, and the bowel consists of your small intestines and your large intestines. So the stomach empties chyme, which is gastric juices and partially digested food, into the small intestines. And from the small intestines, it goes to the large intestines. So the small intestines consist of three structures: your duodenum, your jejunum, and your ileum. And pancreatic function begins when the chyme enters the duodenum. Now, so remember we said the gastric contents in the stomach are more on the acidic side. Well, when the chyme enters the duodenum, the pH changes slightly to become a little more alkaline than when in the stomach, because you want to protect the lining of the small bowel. So the chyme travels through the small intestines and gets to the ileocecal valve um, in approximately 4 hours after you eat a meal. And the ileocecal valve is what controls the flow of the chyme into the large intestines. This valve is there to prevent backflow of the digestive products. So from the small intestines, um, once it passes that ileocecal valve, it goes into the large intestines. So the large intestines consist of your ascending colon, your transverse colon, and your descending colon. And then you have your sigmoid colon, in which this is where the feces or stool stays until it's ready to exit the body. When it's time to exit the body, it goes through the rectum and out the anus. And so, usually within 12 hours, after you've eaten something, you should be excreting that. But a small portion can remain um, for up to 3 days in the rectum. If after 3 days, you know, uh, it hasn't exited, then person can start to become constipated. Okay, so um, there's four layers to the intestines: the mucosa, the submucosa, the muscular layer, and the serous layer. And so these four layers help to support the function of digestion, absorption, and peristaltic activity in the bowel. And so the functions of the bowel, the small intestines, it's that's where, well, first of all, your liver produces what's called bile, B-I-L-E, bile. And the liver then sends the bile to the gallbladder, where the bile is stored until you eat. And then once you eat, it's released into the duodenum. The bile helps to break down fats. So when you eat a fatty meal, bile is released into the duodenum to help break down the fats. It breaks down fats, and it also gives the stool its color. So that happens in the small intestines. The villi in the small intestines also helps to absorb nutrients. And so the large intestines um, helps to absorb the water, the sodium, the chloride. And that's why when you have the more it goes along that intestine. So remember we said you have the ascending colon, the transverse colon, and the descending colon. So the water gets absorbed as it's traveling through the large intestines. So when it's the stool's in the ascending colon, it's just getting into the intestines. So that stool is going to be pretty liquidy at that point, because it hasn't gone through the large intestines completely. When it gets to the transverse colon, some water has been absorbed, so it's not as liquidy. And then by the time it gets to the descending colon, the it should be more formed because more water has been absorbed. And so remember, I said it can stay um, in the rectum for up to 3 days, and after that you start to get constipated. Well, if the stool continues to sit there and more water gets to be absorbed, then the stool is going to become more hardened and cause constipation. So you should be um, expelling that, on a regular basis. Um, uh, so the stool, like I said, the stool becomes more formed as it travels throughout the large intestines. Another term I want to make sure you understand is peristalsis. Peristalsis is what moves the chyme and the gas through the intestines, and that's what you hear when you're listening the to the bowel sounds. Okay, changes that occur in the GI tract, um, as well as changes in the functions of other body systems in elderly individuals can lead to changes in bowel elimination patterns. So it's important for nurses to educate our elderly patients about these changes and about ways to minimize adverse effects of these changes. So, for example, a normal change that occurs with aging is decreased intestinal mobility. And so patients need to know that um, a decrease in the number of stools they're having does not necessarily mean they're experiencing constipation. So instead, you want to educate your patients on the importance of making sure they drink sufficient amounts of fluid and they eat fiber-rich foods, and being active also to help prevent constipation. Constipation being hard, dry, infrequent stools that are difficult to expel from the intestinal tract. And so, that can occur, constipation can occur from um, uh, as a result of decreased intestinal mobility. But by doing these things, they can prevent constipation from occurring. So, like I said, they can have atrophy of the villi. The villi is what helps to um, move the gastric contents along the path of the intestines. Decreased absorption of fat and vitamin B12, like I said, decreasing the motility. And so, bowel habits should not change in a normal, healthy adult. So, healthy lifestyle choices to prevent GI disorders. Like I said, you want to eat a normal, well balanced diet, maintain good oral health, consume sufficient bulk, drink at least 8 glasses of fluid a day, and defecate when you need to defecate. Don't just let it sit there. Go ahead and defecate when you need to defecate. Okay, so your stool should be a light to dark brown, and it should be soft and formed. The appearance of it can be affected by your diet and whether you're metabolizing, your metabolism can all, affect it. So now, things that are abnormal, you should not have blood in the stool. So as a typical rule of thumb, um, the darker the blood in the stool, then the higher up in the GI tract the bleeding is probably, and the more fresh red blood, it's going to be lower in the GI tract. Um, Abnormal will also be a pale white, light gray stool. That could be an indication of absence of bile, the bile, absence of that. Because remember, we said the bile is what gives the stool its color and it helps to break down the fat in the stool. So if you don't have that, you could have that light gray, clay colored looking type stool. Large amounts of mucus, fat, pus, or parasites should not be in the blood and in the stool either. Okay, so remember I said constipation is hard, dry, infrequent stools that are difficult to expel from the intestinal tract, right? And so constipation can occur when stool remains in the colon for extended periods of time. Remember I said that defecate when you need to defecate, because one of the functions of the large intestines is to absorb the fluids. So if it remains in the colon for an extended period of time, excess water is going to be absorbed from the contents, and then the stool becomes hard, dry, and difficult to pass. And so some causes of constipation: diet that's low in fiber, inadequate fluid intake, physical inactivity, stress, certain neurologic disorders, opioid medications, excessive use of laxatives. Um, all these things can cause a person to, um, become constipated or whatnot. And so we're going to look at when we're assessing the bowels. Um, Remember, we want to assess all four quadrants to determine a normal bowel sounds. So if before you say bowel sounds are absent, you want to listen in each quadrant for 3 to 5 minutes. Each quadrant up to 5 minutes, 3 to 5 minutes minimum. Because if you say bowel sounds are absent, then you're saying that person has a serious situation. Now, it's also important to not automatically assume that a person is constipated because of infrequent bowel movement. Normal elimination patterns can vary from person to person. While one person moves their bowels every day, another person might move them every 2 or 3 days. And so the key is if both of these individuals have soft form stools, then neither one is constipated. But if the person that's going every 2 to 3 days, if their stool is hard, dry, and difficult to pass, then that person probably is experiencing constipation. These are just a list of some drugs that can increase your risk for constipations. So, different narcotics that you use. So if your patient is on pain medications, then you want to monitor them closely to ensure they're not becoming constipation. You may need to call the physician to get an order for stool softener or something like that. So watch them. If they have general anesthesia, diuretics for an extended period of time because you're urinating everything out, sedatives, anticholinergics, calcium channel blockers like your Norvasc or verapamil or something like that can cause constipation. And then these are just a list of drugs that a person might use for if they are constipated. Like I said, stool softeners to help soften the stool. Your common one would be like the Colace. Bulk forming laxatives like Metamucil. Now, you want to make sure you educate your patient if they are using these bulk forming laxatives like Metamucil or something like that. You want to make sure they're drinking plenty of fluids, because if they're not drinking plenty of fluids and they're taking this, then they'll cause the opposite problem and cause themselves to have to become constipated. Um, Other laxatives you can use, like the Dulcolac, Senokot, things like that, and then saline laxatives, such as your milk and magnesias or something like that. Now, raw fruits and vegetables, fruit juices, exercise, those are also good to help with constipation. Um, if you have your patient, do those things, because remember we said inactivity could cause constipation. So exercise is good. And like I said, raw fruits and vegetables and fruit juices can be helpful too. Okay, diarrhea. So diarrhea is the passage of loose or watery stools that's usually uh, on a frequent basis. So you want to make sure you monitor your patients if they say they have diarrhea. Just because they're having mushy stools doesn't necessarily mean it's diarrhea. So if they say they have diarrhea, you want to make sure you see it yourself, because it's going to be loose or watery stools that's frequent. And so it occurs because the food content passes through the GI tract too fast for the nutrients in the water to be absorbed adequately. And so it can happen for a number of reasons. Maybe some type of intolerance to food, stress, anxiety, laxative misuse, um, inflammatory diseases such as like diverticulitis, Crohn's disease, ulcerative colitis, things like that. Um, and diarrhea stools are usually acidic, and they can cause irritation, pain, and bleeding in the perineal area. And so they can be accompanied by some abdominal cramping, as well as a strong urge to pass the stool. And so the nurse should monitor these patients uh, with diarrhea for signs of dehydration, because they are losing a lot of fluids. So you want to monitor your patients for dehydration. Now you see that this diarrhea is under hyperactive bowel sounds. Hyperactive. So remember, normal bowel sounds is 5 to 30 bowel sounds a minute. You should hear 5 to 30 bowel sounds a minute. So if it's less than 5, it will be hypo, Hypo, active, and hyper if it's more than 30 bowel sounds a minute that you would hear. So hyper is Hyper, active bowel sound. So that would be um, when you have diarrhea, you probably have hyperactive bowel sounds. And so people who experience diarrhea can experience diarrhea from antibiotics, if they, excessive use of antibiotics or something like that. And so when patients have difficulty with diarrhea, um, because of that, some things that you can do to replace the normal flora are eating things like yogurt, drinking buttermilk, um, um, taking acidophilus, which is an over-the-counter. You can get that over the counter, okay? And the reason being because the antibiotics kill the normal um, bowel bacteria, and so then that causes the diarrhea. So, nursing interventions for a patient with diarrhea. We want to monitor INOs, because remember we said these people are at risk for dehydration because they're losing so much fluids. And so we want to monitor INOs, we want to monitor weight. Obviously, we're probably going to administer antidiarrheals, replace their fluids because they're losing a lot of fluids, monitor electrolytes. Like we said, we're going to monitor for signs of dehydration. You can also uh, things like Gatorade that can help replace your electrolytes as well. You want to avoid gastric stimulants. Caffeine products are gastric stimulants, and so we don't want to stimulate the gastric juices. So we want to avoid those things, and also making sure we educate our patient on good hand hygiene. Okay, so fecal incontinence. This is different than diarrhea. Fecal incontinence, when we talk about incontinence, just like with urinary incontinence, it's involuntary elimination of stool. And so it's often associated with like a neurologic or mental impairment. So, like maybe a stroke or paralysis or confusion, disorientation, if they have some type of traumatic injury or illness or something like that. And a person who has diarrhea may experience fecal incontinence if he or she can't control the strong urge to eliminate. And that a lot of times that does accompany diarrhea. So just think about what this does to a person's dignity, especially if they're aware um, and have all their mental faculties about themselves. They're probably embarrassed, have loss of self-respect and some anxiety about this as well. So you want to be cognizant of that. Also, these individuals are at risk for impaired skin integrity. So we want to make sure we're keeping them clean and maintaining skin integrity for these individuals as well. Okay, assessment of bowel elimination patterns can be a little tricky. Most patients consider this to be rather private and sometimes get embarrassed to disclose information about their normal bowel elimination patterns. So the nurse has to establish a good rapport with the patient. You want to rely on a keen observational skills to ensure the information obtained truly reflects the patient's current bowel elimination pattern. You want to make sure you have information that comes from their nursing history, their lab results, their diagnostic test results, and a physical examination. So initially, we're going to ask questions such as, does the patient have bowel problems? Because that would be, priority. What's their usual bowel pattern? Any measures used to promote defecation? Um, so do they use laxatives? Do they use enemas? Things like that. Because remember, we said abusive laxatives can also put them at risk for constipation. What's their usual eating habits and do they exercise? So we're trying to see, do they eat um, uh, high fiber diet, drink plenty of fluids, things like that. Exercise, because remember we said inactivity can increase your risk for constipation. Um, what kind of foods are they eating? Are they eating foods that produce diarrhea or constipation, and any disorders that might contribute to constipation or um, diarrhea? All right, so when we're doing our physical assessment for the bowels, um, we're gonna first thing we're gonna do is inspect. We're always gonna inspect first, but then the second thing we want to do is auscultate. We need to auscultate before we palpate or percuss. But once you start to palpate and percuss, then you can change the normal pattern of the bowel, and we want to listen before we start changing the pattern of the bowel. So we're going to inspect, auscultate, percuss, and palpate. Now, remember I said US LPNs will probably not be percussing because it does take a special skill to really understand what you're listening to when you're percussing. So, inspection. What are we inspecting for? We want to inspect, does the person have any does the person have any wounds, any lesions, any rashes? Is it round? Is it flat? Is it distended? We're inspecting for, do they have any tubes? Do they have any drainage tubes? Do they have an ostomy? Do they have a peg tube? If so, we're going to assess those things as well. So we're inspecting. Inspecting is looking at and seeing what's going on. Second, we're going to auscultate. We're going to auscultate all four quadrants. You're going to start in the right lower, work your way up to the right upper, then over to the left upper, then down to the left lower. And so remember, we said a person should have normal bowel sounds are 5 to 30 bowel sounds a minute. Is what you should typically hear. If it's less than 5, it would be hypoactive. More than 5 would be hyperactive. And so we're listening for that in all four quadrants. And then, like I said, lastly, we're going to palpate. So we're palpating to determine Do we feel any organs? We shouldn't feel any organs, but do we feel any organs? Do we feel any masses? Do we feel any lumps? Any is there tenderness when we press in? Does the patient have pain when we press in? Or rebound tenderness? Rebound tenderness is when we press in and release. Upon that release is when they have the pain or discomfort. And so we're palpating all four quadrants for that as well. So again, when we palpate, we start in the right lower, work our way up to the right upper, then over to the left upper, then down to the left lower. So we want to go in this direction because if there is anything in the bowel, we want to push it in the direction of moving out versus backwards up in the bowel. So you want to palpate in that direction to ensure you're palpating in the right, moving anything out of the bowel that might be in there. Okay, question one. The most serious abnormality in the stool is the answer here is going to be blood, number four. So blood in the stool is the most serious abnormality. It might indicate active bleeding if it's bright red. And so mucus might indicate an irritation or inflammation of the inner surface of the intestines. White stool would be an indication of there's an absence of bile in the intestines. And parasites are usually like tapeworms, pinworms, or roundworms. Okay, so rectal suppositories are another uh, item that can be used to try to help uh, promote bowel movements if a person is constipated. Um, and so what they do is stimulate the inner surface of the rectum, and so they increase your urge to or need to defecate. Okay, enema is another thing that can be used for temporary relief of constipation. It may also be used for preparation of GI tests like a colonoscopy or something like that. Um, I also put a video on Blackboard for you to see how an enema is administered, so you can take a look at that. All right, if constipation is not resolved, then an impaction will occur and may possibly require manual removal because the patient will not be able to pass the stool um, under his or her own power. And so fecal impaction is considered a collection of hardened stools that's in the large intestines. So the nurse should suspect an impaction if the client has not had a bowel movement for several days, if the rectal fullness is accompanied by several attempts to have a bowel movement, but you're not able to. Or also if there's involuntary seepage of loose stool from the rectum because the stool is trying to that uh, get around that hardened stool. Okay, so bowel training can be most beneficial for patients who are recovering from neurologic disorders and still maintain some muscular control over bowel evacuation. The patient attempts to, so the goal is to establish set times for elimination. And so it might also require some diet adjustments and medications. So you want to make sure they have adequate diet, sufficient fluids, adequate exercise, sufficient rest. And so this program is going to take some time. And so, don't just think it's going to work overnight or whatever. So it's going to require some, patience and diligence. It might require digital stimulation to relax the anal sphincter. Maybe some suppositories or stool softeners or bulk laxatives can be used as part of the program as well. So when we talk about set times, maybe 30 minutes after the person eat, we put them in the bathroom give them some privacy or whatnot. If a person is bedbound and they're on uh, uh, a using the restroom, on a bedpan, then we want to make sure we set them up in a sitting position because that's the normal pattern or the normal position for eliminating. So sit them up in a normal position and give them privacy so that they, feel comfortable um, going. Okay, so some disorders of the GI tract require the removal of a portion of the small or large intestines, or possibly even both. Um, in this case, it could be temporary or it could be permanent. And so it's called a bowel diversion. So a bowel diversion can also be called a fecal diversion. And so it requires that a segment of the small or large intestines be brought through to the abdominal wall, which creates an alternate route for evacuation of the fecal matter from the intestinal tract. The actual opening itself is called a stoma or ostomy. Okay, so the types of ostomies can either be like a ileostomy or a colostomy. A ileostomy would be in the ileum, and the colostomy would be in the colon or the large intestines. So remember, we said the large intestines is where um, the water is being absorbed, and so the ileostomy, if it's in the ileum, the small intestines, that's the last part of the small intestines. Remember, that has not gone through the large intestines yet. So the stool in an ileostomy is going to be very, very liquidy. A colostomy, you can have a colostomy in the ascending colon, the transverse colon, or the descending colon. And so depending on which area the colostomy is located will depend on what the stool looks like. So if it's in the ascending colon, remember that stool has not gone through the colon yet for the fluid to be absorbed. And so that stool there is going to be very liquidy as well. If it's in the transverse colon, then it's not going to be formed, but it's not going to be as liquidy either because it's gone through the colon a little bit, and so some of the fluid has already been absorbed. And if it's in the descending colon, then it's going to have gone through the colon. So the stool in the descending colon will be more formed. Um, so remember, okay, excuse me. So the stoma color should be anywhere from pink to red in color. If it's bluish discoloration or cyanosis, that would be a sign of poor circulation. And so that needs to be reported immediately. You want to clean the skin thoroughly with a mild soap and water and allow it to dry before you apply the drainage bag. Um, so you want to be able to promote a secure seal, with the skin and prevent leakage of the stool. Um, and we don't want stool, getting on the skin because it can cause skin breakdown. Now, a person with an ostomy, they could take a shower and get in the shower. It just would be a matter of, um, could they get through the shower without stool leaking? Now, a person with an ileostomy or a colostomy that's in the ascending colon, they probably wouldn't get through a shower without it leaking because it's constantly, running or whatnot. And so, but if it's more in the descending colon and it's where it would be more formed, and then they probably know, probably 30 minutes after I eat, this is, it's going to start coming out. So they could probably, time it and get through a shower without any stool leaking at that point. But you want to clean it with mild soap and water, pat it dry. You can apply a skin barrier paste as well. You want to select a drainage bag with an opening that properly matches the size of the stoma. Some bags come with a pre-cut opening, but others require the opening to be cut. So you want it about 1/8 inch, wider than the stoma, because you don't want the opening too large because it'll allow stool to come in contact with the skin um, and the surrounding stoma, and so that can cause skin irritation and skin breakdown. But yet you don't want it too snug around the stoma, because then it can cut off the circulation, um, blood circulation to the stoma, and so we don't want that either. Um, you want to teach the patient how to properly care for the stoma at home, um, how to apply the drainage bag, how to change the whole system, how to empty the bag, how to perform good skin care, make sure they understand any signs of complications, right? To identify those things. You want to teach them to empty the ostomy bag when it's half full, because if it gets too full, then it can uh, start to pull that wafer away from the skin and cause leakage. Okay, question 4. Barbara's patient is trying to understand the difference between an ileostomy and a colostomy. Barbara explains to her patient. The answer here is going to be number 3. An ileostomy has more liquid effluent, and the colostomy has effluent that is more formed. Um, so remember, right, depending on which area the colostomy might be in, it'll be a little more formed than that in the ileostomy.